Thank you, everyone, so much for joining us for our MedCu University webinar. Today, we are talking about closing venous ulcers with regenerative copper dressings. And this is a very special session. We run fairly regular webinars, but this is a little bit unique because it's designed to be very practical. We're hoping that you're going to walk away with some tips about using copper dressings, answers to any of your clinical questions that you might have. So this is really an opportunity for you to get, it's hard to say hands-on when we're all on Zoom, but as intimate as possible. And we have two excellent speakers today. First of all, we have Dr. Gadi Barkov, MedCu's chief scientist. He's going to be giving a bit of an overview of the science behind copper dressings. And then we're going to move to Dr. Sergey Karpanyuk from the Department of Surgery at the Chernobyl National Medical University in the Ukraine. And he has seen a lot of success working with copper dressings. And so this is a great resource for you to ask questions, see some case studies, and really understand what does it mean to use copper dressings practically in your own clinic. So we'll hand over to Dr. Barko. If you have any questions, feel free to put them in the chat, and we're going to come back to them at the end of the session.
Thank you, Rachel, for the introduction. Hello, everyone. So I will try to give you some insights into why we're using copper in order to treat venous ulcers. But first, let's talk a little bit in a more widely overview about venous ulcers. So actually, 0.32% of the population, the global population, suffers from venous ulcers. In Western adult populations, we're talking about 1 to 3%. And in adults over 65 years of age, actually 4.5%. And there are studies showing that 60 to 70% of those individuals actually will have a recurrent venous ulcers within a year after healing. And obviously, the chronic venous ulcers are very, very costly to the healthcare systems. Just as an example, in the UK, a healed ulcer costs around £3,000, but an unhealed ulcer due to the treatment goes up to almost 4 to 5 times higher cost, closer to 13.5k pounds. So this really is a very, very significant healthcare constraint on the budget. Let's try to understand why do we get venous ulcers. So first of all, in a healthy individual, healthy venous normal, there is a normal flow of the blood that goes against the gravity back to the heart. And this occurs through one-way valves, which prevent the backward flow, and also through the calf muscles compression of the veins. This is in a healthy state, but in a disease state, actually, the valves do not work anymore. They do not prevent the reflux, and the muscle pump doesn't work. And all this together causes not only reflux, but actually blood pooling, an increase in the hypertension, which causes the leakage of the blood into the surrounding tissues. So by the slowing down of the flow of the blood actually triggers a false alarm, and the capillaries actually are clogged, or the cells adhere to the vessels, to the wall of the vessels, and they are trapped there. And this includes inflammatory cells, and I will talk more in an even more detail later on about the macrophages, which play a very important role here. But these cells, the macrophages and the neutrophils, actually, once they are trapped, they actually start to secrete pro-inflammatory cytokines like tumor necrosis factor alpha and interleukin-1. In addition to that, they also cause the secretion of matrix metalloproteinases. And I want to talk a little bit more about these key enzymes. These enzymes are the ones who are supposed to be able to be able. There are enzymes which basically, because of the over-inflammatory environment, what they start to do is actually to destroy the extracellular matrix. The extracellular matrix, which is composed mainly of collagen and elastin, starts to be degraded by the over-inflammatory environment and response, especially of these matrix metalloproteinases. Also, these enzymes start to destroy adhesion molecules and vital growth factors, which are needed for the normal wound healing process. So this eventually leads to the loss of the structure and the integrity, and the wounds also, or the tissues cannot repair themselves due to the over-inflammatory environment. So eventually, the combination of the lack of oxygen, the hypoxia, together with the over-inflammatory response and the severe tissue degradation leads to the formation of the venous ulcers. In addition to that, it's important to understand that once an ulcer is formed, almost universally, it becomes contaminated by bacteria, and which form what we call a biofilm, a mature biofilm, which gives protection to the bacteria from the environment, from the host immune cells, and obviously from systemic antibiotics, and also from other, let's say, antimicrobial agents. So the continuous presence of the biofilm not only prevents the treatment of the wound by the antibiotics, etc., but also it activates phagocytes and increases the activity of the matrix metalloproteinases. And all this actually causes the altering of the natural autolytic debridement process. So the presence of the bacteria and the biofilm is critical, and it's very important to be able to remove the biofilm. So today, when we're talking about clinical intervention, so obviously we're talking about compression therapy, and you need to apply in order to reduce the venous reflux and the edema that it may cause. But in addition to that, in some cases, there is surgery intervention or some pharmacological support. But I want to talk more about the local wound care, how to optimize the wound bed. So obviously, one of the clinical intervention is the debridement of the necrotic tissue, making sure you have good moisture in the wound bed, and you want to get rid of the bacterial colonization. But unfortunately, chronic wounds, as I said, are trapped in a state of prolonged localized inflammation, which activates the metalloproteinases and gives a physical barrier. So once again, I'm trying to stress out the critical point, or the critical importance to have an effective debridement. This is critical for good healing, and chronic wounds lack the capacity to get rid of the necrotic tissue by themselves. So today, for example, they are using surgical debridement or other types of debridement, and when you do that, you get rid of the biofilm. And unfortunately, some of the bacteria, residual bacteria, are not you cannot completely remove all the bacteria. And these bacteria, which survive very quickly within 48 to 72 hours, are able to form new biofilm. So while you have a window in which you can be able to have some effect on the wound healing process, very quickly you will have once again biofilm being formed. And as you all know, usually the patients are not treated on a daily basis, but they come once or twice a week to the clinic. So here's where we come into play. And before I get more into the details of how we come into play, I want to show you a short video which gives an overview of what we said, and we will go a little bit more into detail in a second.
Our bodies are amazing healers. Sometimes that healing process just gets stuck. Why is that? You know that wound that just won't heal? A lot of the time, it's because it's clogged with old, non-viable tissue. But get this, your body has its own built-in, totally painless, self-cleaning process to handle it. It's called autolytic debridement, and it's all run by a team of microscopic workers. Meet the cleanup crew. They're enzymes called matrix metalloproteinases, or MMPs for short. And this crew is super specialized. You've got different MMPs for different jobs, from clearing tough fibers to dissolving filler. Here's the problem, though. In chronic wounds, this whole system goes haywire. The crew gets totally unbalanced. For example, MMP8 is a helpful worker, but MMP9, if it's unregulated, it goes rogue and gets destructive. When that balance is off, healing stalls. It actually destroys helpful growth factors, and the wound just can't get cleared. So, the big question is, how do we get this crew back in order and working properly again? This is where copper comes in. It acts like a master regulator, kind of like a foreman for the cleanup crew. See, copper isn't some foreign substance. It's an essential element that our body actually needs to heal. As copper ions enter the wound, they signal the body to make more of the helpful, good guy MMPs. But it also boosts their supervisors, called TIMPs. This creates that perfect balance between demolition and control. And you can see that influence right here. Copper precisely adjusts the levels of both the MMPs and their inhibitors. With that balance restored, the body's own self-cleaning process gets a massive supercharge. So what happens then? Dead tissue and biofilms get cleared out much faster, and the wound is finally prepped for new growth. And this is the main takeaway. Copper doesn't just support healing, it actively enhances the body's own ability to self-debride. It really makes you wonder, right? Could a simple element be the key to unlocking our body's most stubborn healing challenges?
So here, let me remind you, first of all, that our dressings have been shown to effectively kill bacteria even when they are protected by biofilm. So this is obviously a very important property of our dressings. But the other thing that I want to talk a little bit more is what you have seen now in this short video, is the role that copper plays in the autolytic debridement, and more specifically about the MMPs, metalloproteinases modulation. So if this is a molecule, one of the metalloproteinases, they need usually zinc in order to have the molecular structure. But when copper actually is able to replace the zinc in the active site, there is a structural shift which actually enhances the activity of these metalloproteinases, and it increases its capacity to break down the dense necrotic collagenase fibers, the necrotic tissue. So this is in a way helping the body to get rid of the necrotic tissue. And another thing which was mentioned in the video are the TIMPs, the tissue inhibitors of metalloproteinases. Actually, as you understood, in an inflammatory state, in a chronic wound, the control of the metalloproteinases is not going as it should be. But in the presence of copper, actually, and this is something that we have to research more, copper resets the wound from a state of destructive chronicity to a state of healthy, regulated proteolysis by influencing some of the key metalloproteinases like MMP8, for example, or 1, and stimulating the upregulation of the TIMP1 and TIMP2. So another important cell that I mentioned before are the macrophages. The macrophages, when they are in the chronic venous ulcer, they are what's called in an M1 phenotype. They secrete pro-inflammatory cytokines. And it's very important to be able to switch them to secrete what's called pro-healing cytokines. And this is done by copper. Copper has been shown to be uptaken by the macrophages, where once they are uptaking, they regulate different signaling molecules which stop the excessive inflammatory amplification, and the macrophages shift to the M2 phenotype, which allows them to be able to engulf and clear all the necrotic debris. So the main message here is that copper actively reprograms the cellular cleanup crew, specifically the macrophages, converting stagnated inflammatory cells into efficient debridement engines. So when we look at the whole process, the fact that copper can affect the metalloproteinases, help remove the physical epoxic barrier, the biofilm, and eventually once that is clear, all the necrotic tissue is clear, they are able to stabilize IF1 alpha, as we mentioned in the past, which allows the stimulation of production of vascular endothelial growth factor and eventually to the regeneration of the production of the new vasculature. And when we compare ourselves to other modalities of debridement, like surgical, mechanical, or enzymatic, I will not get into all of them, but I want to emphasize that our dressings can selectively enhance the autolytic debridement process very effectively without much pain, because it's conducted by the body itself. It doesn't cost much. It's part of the wound dressing itself, and it's highly tissue sparing. It doesn't damage the healthy cells. So the idea here is to shift from an intermediate to a continuous debridement process. Today, the traditional sharp debridement is able to control biofilm, but only for very short periods of time. It actually needs skills from the people conducting this procedure, and in many cases, it damages the healthy tissues, and it causes pain to the patient. By our dressings, you have continuous 24/7 permanently continuous debridement. You prevent the reestablishment of the biofilm. You spare the healthy tissue from damage. And obviously here you stimulate the native autolytic debridement mechanisms with very small pain, if at all. And just as another reminder, we talked that in the past, that our dressing can be used from skin rupture all the way until skin closure, because they have a potent antimicrobial efficacy. They stimulate the autolytic debridement process through the MMPs and TIMPs axis. It stimulates the production of new blood capillaries, and it's also involved in the final remodeling of the extracellular matrix, as it a key cofactor of some of these key proteins, like lysyl oxidase, involved in the remodeling of the tissues in the wound as it heals. So with that, I will stop my share, and I will give Dr. Karpenyuk his opportunity to present his data.
Good afternoon, everybody. Good afternoon, Dr. Gadi. It's a great pleasure to be with you today. It's always very emotional and positive. So, do you see my screen?
We do.
Okay, so closing venous ulcers with copper dressing. I have no conflict of interest. And before I start, I want to underline that in my everyday job, we are using consensus documents of European Wound Association to be truthful and to work as it has to be. So venous ulcer, according to Scottish guideline, is an ulcer on a leg having a venous disease. But speaking about French healthcare guidelines, pure venous ulcer is an ulcer due to ambulatory venous hypertension, which is secondary to reflux of superficial perforating deep veins, or obstruction or dysfunction of muscle calf pump, but without any arterial involvement. So, in my understanding and in guideline understanding, venous ulcer is a leg ulcer having a venous hypertension. And in our everyday work, we understand venous ulcer, every ulcer on a leg without any arterial involvement, without any atypical wounds, and having a lymphedema. So speaking about treatment, a cornerstone of treatment is compression. And as you can see, the level of healing rate at the best randomized trial studies at 24 weeks with compression is 72-67%, comparing to 29% without compression. But there is still insufficient data about wound healing, speaking about venous ulcers, but in general, 93% of all wounds has to be epithelialized in 12 months, and 7% of ulcers do not heal even after 5 years. But the criterion of effectiveness of venous ulcer treatment is a regression of the wound area more than 40% during the first 4 weeks of treatment. So this is the aim. But in real life, when we are talking about wound care registers, especially in United States, so there is a state wound injury register, and you can see that venous ulcer is healing within 12 weeks only in 44%. But there was a great study of Dr. Caroline dealing with different hard-to-heal wounds, and she says that after analyzing different randomized trials, after analyzing state register and clinic register, to heal a venous ulcer in 12 weeks in 40% is almost reachless. So we are doing the best. But before I start, I want to underline that almost every visit to our clinic, we are making a photo fixation dealing with 2D mode and making data in a patient protocol. All our patients in this study determined TBPI and duplex venous ultrasound examination of the legs. All patients were using multi-layered component compression system from distal part of leg to the knee. The layering application technique, quantitative and qualitative composition of the bandage components, and the level of compression were determined according to the configuration of the limb, its circumference, and patient's movement, is it active or passive, and were selected in each case individually. Also, bandage was replaced on each visit, and edema regression was assessed visually using simple tape. We are using different types of bandages, long stretch bandage, short stretch bandage, underlaying, cohesive and simple, and our aim is to reach as much higher pressure as we can do because the aim is 40-50 millimeters of mercury, depending is there any contraindications or no. Also, everything you will see today, every patient has no any pharmacological agents, no any other medical products, nutritional supplements, or any other procedures such as oxygen therapy, vac therapy, lymphatic drainage, or others. In case needed, such type of help like cardiology, nephrology, or endocrinology specialists were involved in case of needed, and a leg ulcer were treated according to time concept, and we are using only sharp and mechanical debridement in case needed, and using mechanical debridement, we are using cleanser solutions or simple saline. In case needed, each patient during dressing changing have used antiseptics, but it was very rare. I even can say no. And dressing were performed during every time of visit. So all patients were instructed about how to use compression therapy, how to treat, how to prevent recurrence, and the follow-up after complete healing was after 72 hours and 14 days respectively. So let's see how it looks like. First clinical case is 74 years male with post-thrombotic syndrome and having an ulcer for 12 months. So you can see on the 6th of February a huge wound on a leg with full of debris and necrosis without any signs of healing. And in 6 days, we have debrided a wound without any sharp technique, just MedCu and compression. And you can see how in 14 days the wound is healing, the granulation tissue is very strong, nice, clean, and there is a very nice epithelialization from all around. And we continue, and on 25th of February, you can see, I think that this is like a perfect granulation tissue without any infection, without any debris, without nothing. It's very clean and very active epithelialization. We moved on, and in 58 days, the wound was completely healed. So in mathematics, you can see that healing rate is like 100% for 58 days. Next case is a female, 52 years old with secondary lymphedema and wound existence for 6 months. So you can see this huge lymphedema, this hyperexudation wound with macerating edges, full of debris wound bed, and no signs of healing on the 19th of March. And then in 10 days, the wound was completely debrided without any additional devices, without any sharp technique, without nothing, just changing MedCu dressing and compression therapy. And 10th of April, the wound is actively epithelialized. And then you can see, like in 39 days, the wound was completely healed. So 39 days to complete epithelialization, and you can see how the wound was regressing during each visit. Next case is 80 years old male with also secondary lymphedema and wound existence for 12 months. That guy has a wound on the area of Achilles, as you can see. He has used tons of antibiotics, different procedures, ambulatory and inpatient treatment, and nothing helped. It was very painful because each movement of the leg was like great trauma for this area. And on the 23rd of February, we have started. We have used just MedCu without any gels. We were rinsing MedCu with cleanser, applying to the wound, and compression. I want to underline that all these cases is like ambulatory patients. They are moving, they are walking, they are doing their daily job, and we don't actually know how much do they work or how much do they walk. So as you see, at the 18th of April, the wound was almost healed without any problems, without any additional antibiotics or anything else, and in 80 days, totally epithelialized. So 57 years old male with post-thrombotic syndrome and wound existence in 3 months. As you can see, the skin changes and a deep wound on the front of the cuff, and with full of necrotic and debris tissues, and we even saw that the bone can be in the wound bed. But in 59 days, using just MedCu and copper dressing, you can see how skin has changed. There was no any infection or any other adverse events, and the skin that has grown is looking like perfect. Another case is 70 years old male with secondary lymphedema and wound existence for 6 months. It is also like not very easy area because medial ankle is like every time is moving. There is a lot of trauma, and that male was treating that wound unsuccessfully. You can see how deep it is, and full of debris and necrotic tissue on the 13th of March, and then not in a full month, it was almost totally epithelialized. And why we still was working 1 month more? Because the wound was deep, and that small area was very hard to fulfill with granulation tissue because of scars and everyday walking and trauma. But in 58 days, the wound was totally healed. So another case is 67 years old male, also with post-thrombotic syndrome and wound existence for 9 months. You can see full of debris, full of necrotic tissue, and you can see this huge edema and skin changes, as Dr. Gary says. And that patient has previously twice venectomy in the past, but the wound still did not heal. So 20 of February we started, and you can see in 7 days how the wound was perfectly cleaned, how the skin is growing, and how nice and clean granulation tissue is growing. I want also to underline that all these patients are using high compression therapy, and you can see that even under 50 millimeters of mercury at the ankle, there is no any issue with the dressing. There is no any print or any skin damage. So it works perfectly. And in dynamics, in 39 days, 1st of April, wound was healed totally. So in numbers, it looks like this. So the wound was regressed to 100%. Another case is a female also with post-thrombotic syndrome and wound existence over 20 years. It is very interesting case because that lady has passed deep venous surgery, and to my mind it was unsuccessful because there was very stable and very high edema, and it was very hard to struggle with it. So on the 17th of November, we see a huge wound for 20 years old and full of debris and necrotic tissue on the leg. And then not just in 4 days, you can see how autolytic debridement is working, just copper-based dressing and compression. And you can see in dynamics in 2 weeks, ideal granulation tissue growing. We can see the area of avascular wound bed, but in spite of that, very nice epithelialization is growing. And you can see that when you are taking off and pulling out the dressing, there is actually nothing to do. The wound is so clean that you just have to change the dressing, maybe spray some saline to clean peri-wound skin or something like that, and nothing more. Another case is 50 years old female with secondary lymphedema and 12 months wound existence. It is very interesting case also because that lady has obesity. She was like 20, please excuse, she was like 225 kilograms of weight, and she was treating this wound in different clinics unsuccessfully because everybody says because of obesity. So 13th of June we have started. It was not easy to apply a compression therapy on such type of leg, but we have tried, and you can see during the days how the wounds transformed, how necrotic tissue was debrided and granulation tissue is growing, and in 83 days, in spite of such weight, in spite of such edema, using copper-based dressing, we have healed the wound totally. Another case is 67 years old female, and I just want to make my presentation more interesting because this is very interesting case because this lady has immune disorder. She is on a steroid therapy with systemic thrombocytopenia, and she has an injury of a leg a month ago, and treating in a hospital without any results. So it is very interesting because as we know, steroids has a negative influence on a wound healing, so it's not very easy every time. 9th of February, such type of wound was at initial, and you can see necrotic and debris tissues and undermining due to hematoma flap. But in a month, we grow active granulation tissue, even using steroids, and active epithelialization. And in 70 days, visiting a doctor twice a week, have a normal life and activity using compression therapy and copper-based dressing, the wound was totally healed in spite of steroids prescription. Another case to make it more interesting is a 73 years old female with secondary lymphedema and wound existence for 1.5 months. This is very interesting case because such architecture of leg, those who are working with wounds know how it's not easy to pack the leg, how it's not easy to make it safe, and how it's not easy to make a compression. You see this foot deformity, and this lady has lots of recurrences of ulcer, and you can see scar skin changing and blanch atrophy, and everybody knows that compression at the tooth is not so very easy. There are usually lots of edema, lots of exudation, and having a lot of exudation on such damaged skin, the wound usually becomes bigger, and the skin is macerated. So 23rd of January, we have started using MedCu due to such deformity. The lady was visiting our clinic twice per week at the beginning, and at the middle of treatment, she was visiting us like once per week. So you can see how safe was using MedCu. there is no any maceration, there is no any skin damage, but still it is like moist environment. So it's not dry, but it's not wet. So it's balanced. And you can see in 3 months how easy, without any without any adverse events, without any problems, with comfort to a patient, just 1 time per week of dressing changing, we totally healed the wound. Also, another case is very interesting because it's like 92 years old female with arterial involvement after revascularization. She has such type of wound. It was treated unsuccessfully because at first it was treated like arterial ulcer, and then making successful revascularization, it becomes venous ulcers. But nobody has managed edema, and nobody was treating an ulcer in the right way. So just MedCu and compression therapy on the 11th of March. As you can see, tons of tendons, tons of necrotic tissue, and just in 10 days, the wound was totally debrided without any scalpel, without any sharp technique, just mechanical debridement and MedCu. As Dr. Gadi says, we need continuous debridement, so it should work every minute, and MedCu is doing exactly what we need. In dynamics, you can see in 64 days, opposite and in spite of elderly and 92 years old, and atherosclerosis and such venous disease, we can see how nice granulation tissue is growing, and tendons already covered by granulation tissue, and epithelium is growing on top of it. So 64 days initial and 15th of May. Another case interesting is like 87 years old male with secondary lymphedema. Why I want to show you this case? Because we always met different types of erysipelas. We always met different types of dermatitis, cellulitis, and other maceration skin having deal with venous ulcers. So you can see on the 8th of December, this great inflammation, having an ulcer, and you can see this dermatitis and skin maceration due to high edema, and it's almost erysipelas. And we did not do anything more, just MedCu and compression therapy, and you can see in 3 weeks how edema regressed and how inflammation regressed. We renew epithelium, we debride debris and necrotic tissue in a wound bed, and grow strong and healthy granulation tissue with active epithelialization in 52 days. Another case to prove that it's really working is a lady with anasarca, systemic lymphedema, and such type of ulcer on a leg. You can see how huge lymphedema is, and it's like the almost cellulitis or erysipelas. This lady was treating erysipelas for 3 months, and this wound also appeared. So she has used tons of antibiotics, but it still did not help. And 11th of March, the wound looks like this. But in 7 days after during dressing changing, we can see systemic skin inflammation, and you can see this white pitting, this white folliculitis, and skin inflammation. But I want to show you that on a place where was MedCu, there is no any inflammation, there is no any folliculitis, and it means that it's really have antibacterial effect and dealing with biofilm. On this photo, you can also see the place where there was no MedCu and the place with MedCu. So where was no MedCu, there is folliculitis and skin inflammation. On a place where was MedCu, there is nothing. And 27th of March, covering with MedCu the whole leg and using compression therapy without any antibiotics, without any systemic influence, we have such nice result without any erysipelas or dermatitis. So we continue, and it looks like this. And in 48 days, the ulcer was healed. We have very nice regression of edema on a leg, but still cardiologist has to work with the patient because the lady is full of water. So another case is 74 years old female, also with secondary lymphedema and 12 months wound existence. This is also a very interesting case because in our practice, due to age of patients, due to war in Ukraine, due to social aspects, there may be lots of force majeure situations where a patient cannot reach a hospital. So to present this case, I want to point on 14th of March. It's like a fast visit, and you can see these huge ulcers on both legs. But due to long distance to our clinic, the lady come back to our clinic on the 19th of March. She had pneumonia, and there she was feeling very bad. So we decided not to change dressing, just change compression therapy, because dressings looks very good, and she has left home. But due to pneumonia, she was hospitalized in their local clinic, and nobody has changed dressing till 26th of March. So almost 2 weeks, nobody has changed dressings on a leg, having such full of necrotic tissue, venous ulcers on both legs. So when she came in, the dressings looks like this. So 26th of March, taking out the dressings on a left leg, you can see how autolytic debridement is working. All necrotic tissue is going out, and the main positive, one of the main positive aspects that for this almost 2 weeks, there is no skin maceration, there is no any systemic or local inflammation on the leg in spite of such necrotic tissues in a wound bed. So taking off MedCu and just cleaning the wound, and you have totally almost clean wound on a left leg, and the right leg is the same. And you can see how autolytic debridement is working. You just need just to take off necrotic tissue without any damage, without any bleeding, without any complex techniques, and nothing more, just MedCu and compression. So we go on, and April 6th, left leg, you can see how granulation tissue is growing, how skin is growing, and there is still no any inflammation or maceration. And the right leg, it looks like the same. You can see Achilles on the back of the calf in a wound bed. And then 27th of April, this perfect granulation tissues, we are changing dressing once or maximum twice per week, depends on patient's mobility, and she feels perfect. Another problem and another issue with venous ulcers is horizontal and vertical leakage. So to my mind, MedCu is like much better even wax therapy, because you can see on this photo that there is anything spreading horizontally, and there is any maceration on a peri-wound skin. But there was also a question about how easy to take off and to take on the dressing, because you know that debridement it has to be every dressing changing, and usually using alginate or something else, it takes too much time. There are some types of dressing that we cannot take off from the wound. It's painful. There is some types of dressings where granulation tissue is growing in dressing, causing bleeding. So different aspects. And in this picture, I want to show you how easily MedCu is taking off. So you can see that distal part of wound is more exudating, and it's okay. And the proximal part of wound is more dry, and it is okay too. We did not rinse anything, so no saline, no wetting, just taking off the dressing, and you can see how clean a wound bed is, and there is nothing to do. You just need to spray some saline and cover it again. But sometimes, usually we think that more dry, more hard to take off. But dealing with copper-based dressing, it's not right, because it's always easy to take off, except of one case, except when it is too wet. I mean that the contact layer of dressing is so perfectly done that it is very intimated, I don't know how to say in English, adhesive to the wound bed, and there is no any free space between wound bed and dressing. But having very wet exudation in a wound, the granulation tissue is growing very quick due to MedCu properties, and because of that, usually more wet, more hard it's to take off. But it's not a problem of a dressing, it's a problem of wound exudation, it's a problem of compression therapy, and we even have tried to compare with other dressings. So using other dressings is much more harder to take off, and the wound is full of debris, it's full of fibrin, and there is lots of inflammation. So on the next video, I want to show you how easy is to take off the dressing, and what problems you can have and how to solve it. So the same lady twice per week taking off. You can see the wound is more wet, but it's still controlled, and how easy is to take off the dressing. No bleeding, no damage, no any anesthesia, no any spreading of saline or water, just taking off carefully, and it's work okay. You can see the islands of epithelialization on a wound. So it is island and peripheral. And you can see that there were tons of exudate, but the skin is not macerated. So it's perfect, because usually venous ulcers have such a problem of skin maceration. So you can see how easily we take off the dressing. No any issue, no bleeding, even with such high level of exudation and such long times between dressing changing. Another leg, same patient, so left and right. This is actually the same patient with that totally necrotic wound bed from the previous slides. You also can see that you are debriding not only wound bed, but peripheral skin. Everything is not necessary, is taking off on a dressing too. No inflammation, no damage, and no bleeding. Okay, and another video is a lady with very high exudating wound on May 8th. So on the 8th of May, it is very highly exudating wound with hypergranulation growing, with orthostasis during day long and even nights. And you can see, so in case it is heavy exudating, so you can have such issue. So the wound bed is still very clean, but due to very nice granulation tissue growing and very wet environment, you can receive such bleeding. It means that the wound is very nice debrided, it is very clean, but the sticking of a dressing due to heavy exudating environment can cause such a problem. So why I am showing this? Because 8th of May, and we have such wound. We have worked with lady once again. Cardiologist was consulting once again, and she stopped working all day long, trying to have some horizontal position. And we also have made more high level of compression. And on the 11th of May, the same leg, same patient, same dressing, but you can see that there is much more less exudation, and the dressing is pulling out much more easily, and there is much less wound bed injury. The wound is very clean after taking off the dressing, and there is almost no maceration on a distal part. To take it off much more easily, you can rinse with a saline, but we do not do it in this case because we want to see exact wound bed, and we want to see how the dressing was working. So we go on. And on the 18th of May, same leg, much more higher level of compression, much less edema, as you can see on a foot. And what we have received, the taking off of a dressing is much more easier. Almost without any bleeding, and very nice, strong and healthy granulation tissue growing. I also will go back a little because I want to show you why it is bleeding. So just a moment. So you see 11th of May, after taking off the dressing, we have very clean granulation tissue. But why it was bleeding? Because it is very fragile due to very wet environment. You see, it is like hypergranulated. And that's why when you're taking off the dressing, because it's very wet, it's bleeding. So having hypergranulation tissue, do not using any additional methods, just MedCu and compression, you can reach a very nice result. So having such good results in venous ulcer treatment, as I think, we were trying to make some data, to make some analysis. So we took 30 patients with venous leg ulcers with a wound area from 2 square centimeters in size to 100 square centimeters. As you can see, the age of this group was 66 years old. They all have secondary lymphedema. 9 of them has post-thrombotic syndrome, and 6 of them had venectomy in the past. They all have no any arterial involvement except one patient, but it was not crucial. So all these 30 patients have not received any antibacterial therapy, have not received any pharmacological agents for wound treatment, any nutrition facts, just MedCu and compression. The median ulcer area was 13.7 square centimeters, the lowest value 2 square centimeters, and the highest value 57 square centimeters. At the initial 4 patient has necrotic wound bed, and 26 patient has debris wound bed. no one with avascular, no one with granulation tissue, and no one with epithelialization. And what we have received, all these 30 patients were completely epithelialized, but 90% of cases was completely healed in 12 weeks. The average time to complete healing using survival curve Kaplan-Meier method has 99.5 weeks. The lowest one was 7.8 weeks, and the highest one 11.2 weeks. So having this data, we can truly say it and loud that using compression therapy with MedCu, we can heal 90% of venous ulcers in 12 weeks, not 12 months, but 12 weeks, as you can see. Another thing, we have analyzed how the wound bed has changed during the treatment period. And you can see that on the 7th and 14th day of treatment, 80 and 100% of wound surfaces were transferred to the healing phase with active epithelialization. We also have analyzed the area of wound bed at initial and at the period of 4 weeks of treatment. As you remember at the beginning, as I said to you, the perfect line is more than 40% of wound bed regression at the 4 weeks of treatment. So we received that at the 4 weeks of treatment, our wound area regressed by 66.8% from 13 square centimeters to 4.71. We also have analyzed the times of visit, the dressing changing times. So using simple time concept, usually the patient is visiting a doctor and having dressing changing 3 times per week. So 48, 72 hours between dressing changes. Using MedCu and having an opportunity to do not change so often dressings, we have analyzed the data, and you can see that at the level of 90% of complete healing using a simple time concept, we have 36 visits, and using MedCu with time concept, we have 30 visits. So it means that using copper-based dressing, you can reach much economy effect and much more comfortable to a patient, and you can have more than 20% less dressing changes than simple time concept. So having this data and having different concepts of wound healing, you know that there is like a cornerstone, like a time concept, but using different regenerative agents such as hyaluronic acid and so on. There is timer. Using social aspects, there is timers concept and other modern concepts. And to my mind, we can truly say that we can say about fast time concept using copper. What I mean function that copper-based dressing is giving to our wound bed and to our venous leg ulcer healing. We are talking about all-in-one dressing. I mean that we have a dressing for all stages of wound healing during debridement, granulation, and epithelialization phase. We have one dressing for all type of wound bed architecture. I mean that avascular, hypergranulation, different sinus, undermining edges, deep, and etc. And we have one dressing for all types of peri-wound skin, scars, blanch atrophy, elderly skin, steroid skin, and so others. And we have one dressing for all types of wounds. We can treat leg ulcers, mixed atypical bands, diabetic foot, and others. And it is safe. It is safe for our body. It is safe for bone, for tendons, for vessels. It is safe under high compression therapy, and it is even safe in different force majeure situations such as war zone, different quarantine periods when the patient cannot change the dressing every day or twice per week or 3 times per week. So it is safe even if we do not change it even for 2 weeks. And no possible adverse events, and it is safe even combining with other medical devices. And we are talking about team. Team means medical care specialist, wound care specialist, and team means a patient, because using MedCu, it is very easy for wound care specialists to work with. It is very easy for self-care, and it is very easy for home cares. You don't need to pay, and you do not need to spend too much time for knowledge, for studying what type of dressing, what size of dressing, what side of dressing. Even in case you have some problems with vision, you can use 3-layer dressing and to put what side you want, and it will work. And minimal possible mistakes in choosing of type of dressing. You have one simple and very effective solution: minimal scar formation and best quality wound healing. So mankind was born on Earth and was never meant to die here. Once having a leg ulcer, never meant to live with the leg ulcer. Thanks for your attention, and giving a desk to Dr. Gotti.
Thank you so much again, Dr. Gaddy. We have a whole bunch of questions. Let's start with, do you have any experience in wound healing with patients who are on chronic blood thinners, such as Ecotrin and Zelerato or similar?
As in case I see Xarelto, oh yeah, yes, I understand. Yeah, please, sorry for my English. Yes, we have lots of such cases, and there is no any issue. There is just one issue I have showed you when it is very wet. So in case it is very wet, it can damage a wound bed. But I want to reply, it's not a problem of dressing, because in case you will use even wax therapy or other types of dressing, you can put 2, 3, 4, even 5 layers of alginate, and it will be still more wet, more bleeding, more inflammative. So yes, no problem with any anticoagulants and so on.
Okay, great. Thank you. Now, can MedCu be applied directly onto tendon or bone?
So if you let Dr. Gotti, I will answer. Yes, we are doing it exactly on a bone and on a tendon, without any nets, without any additional material. And we also are preparing another case study about tendons, and it works great, because previously when we have been using carboxymethyl cellulose dressing, polyurethane foam dressing, or even wax therapy covering tendon, it is too wet, and it's like I don't know how to say in English. It is ruining the tendon, but covering the tendon with MedCu in case it is already dead, I mean tendon, necrotic. So it will make a very gentle demarcation of that tendon, and what is still alive will stay alive, and you can cut the dead tissue. And the granulation tissue is growing much faster on a tendon, so no problem. Speaking about the bone, we have been using it very spreadly, very often with diabetic foot, and we are using 3 layers MedCu in different sinus, layering on a bone. We have also used it on an open bone on a leg, and there is no any issue, and the granulation tissue is growing too.
Great, thank you. Can MedCu be used on a wound caused by erysipelas? Sorry, I'm not a doctor. Did that make sense?
Yeah, it's like, yeah.
You don't need to explain. Everyone else knows what it is. I just can't say it.
Yeah. So, just to be clear, I am not talking about that when you have erysipelas with fever, with blood changing, and other aspects, and you don't need antibiotics, just MedCu. I was talking, and I'm talking about that when you have a wound on a leg and you have even erysipelas, or you have such severe dermatitis without fever, without any systemic inflammation, so MedCu and compression can stop it. And having erysipelas, combining it with antibiotic therapy, you will have much much better results without MedCu. So yes, you can do it, but in case of systemic inflammation, you still need antibiotics.
Okay, thank you. Can we use copper dressings on pyoderma granulosa? Developed at
Yes,
the
we are
stoma
doing.
under the breastplate. That was very specific.
We had like 10% of our patients, we have usually pyoderma gangrenosum, and there was a very interesting case, a young lady with pyoderma gangrenosum on a breast and in a genital area. So we were using MedCu, and it works okay. It works very nice because you know that pyoderma is usually concerned with some bacterials and so on and so on. And it works very nice. Actually, we are using MedCu not only on pyoderma, but on all other types of atypical wounds. I mean, Martorell syndrome, different types of vasculitis, and so on and so on, because antibacterial effect and copper-based effect and such effects like no horizontal leakage on such type of wounds and no maceration, so the effect is very nice, so you can freely use it.
Great, thank you. I don't know if this is for you or for Gadi. Someone says that they've been using MedCu with excellent results, but they found that there was a characteristic odor on a few of the patients they used. Is that normal? They're changing the dressings every 3 days.
I'm sure Sergey can also answer to that, Dr. Sergey, but yeah, we have received sometimes feedback that there is some odor. My theory or hypothesis is that it may be an interaction of copper with some of the molecules secreted by the bacteria, which form some kind of malodor. But I don't think it's a big issue. In many cases, actually, when you get rid of the bacteria, you get rid of the odor caused by the bacteria. But maybe Dr. Sergey can tell us more from his experience.
So, Dr. Gadi, we have no such an issue because comparing with other dressings or even wax therapies, there is much more odor than when we are talking about MedCu. And I don't think that this is a problem of dressing because actually lymph has an odor and it's not an issue. We don't see any extra signs or something like that. I even can say that it even less because less maceration, much more fluid capacity of dressing, and there is no so huge hyperexudation, and there is no such odor. So I don't know why people have such an issue. We don't have such an issue.
Okay, great. Daddy, is there any chemical interaction between the copper and HOCl?
There might be. Actually, you may get even an antimicrobial synergistic effect because both of them can cause, reactive oxygen species, etc. So actually, there can be, but obviously, it all depends of the, how do you call it, of the contents. And if it's excessive, let's say HOCl, you may get some type of toxicity. But in general, I think there is no problem in combining both of them. I don't see the need for, but usually, you can use the copper. Our dressing have very potent antimicrobial efficacy, so usually I don't see the reason why to combine, but basically it can be done.
Thank you. Okay, Sergey, someone had a question about the study. Were the patients presented in the case study already receiving compression therapy before you started using the MedCu dressings?
Some of them, yes, but it was very low level of compression, but mostly no. So we are using compression every time and every day. But in this question, if there is a meaning that compression itself helps to heal a wound, but not MedCu. So as I have showed at the beginning, the level of wound healing using high level of compression in the best quality RCTs in 24 weeks is like 70%. We have reached 90% in 12 weeks. So I think that the answer is this.
Great, thank you. And I think that leads us to our final question, which is what is the recommended frequency to change wounds with biofilm to prevent reoccurrence?
So if Dr. Gadi will let me, I will cite him that biofilm recover every 24, 72 hours, yeah? And yes, you can change the dressing every 72 hours or 48 hours. But one of the aim of our study was to show that even have longer periods between dressing changing using MedCu do not doing any mechanical, sharp, or other type of debridement. Using MedCu, it doing it by itself. So due to properties of copper, due to autolytic debridement, even if you will change dressing once per week or even less, it will still work. But it depends on a wound bed, because you need to reshape the edges, you need to check, you need to maybe to give some more moisture, or in case it is too wet, you need to change it more frequently. So it depends on a wound, but it can be from 3 days to 7 or even 10 days.
Okay.
So just to add what Dr. Sergey said, the dressing, as you may all know, has one single dressing has, from a regulatory point of view, a limitation of 7 days. And this limitation was established because we demonstrated that we can kill above 4 log, meaning more than 99.99% of the bacteria on the dressing itself, even when it's completely full with wound exudate for 7 days, and even if the wound dressing was every day inoculated with bacteria. So there is enough copper there to have very good efficacy. We didn't show more than 7 days, but I'm sure it can also continue working after 7 days. But there, so for biofilm, you will prevent the re-establishment of the biofilm. And the reason to change the dressing is mostly because of the amount of exudate, etc., as just now explained, and not because of the biofilm effect.
Wonderful. Thank you, Gary. And oh, another question snuck in. Have you used MedCu with the DFU cavity?
So I think that we need one more webinar about diabetic foot ulcer, because there are tons of information and cases and positive feedback and positive results. And yes, we are using MedCu in diabetic foot and in cavities on a bone, on tendons. So yes, we can do it, but it's like a separate theme, yeah.
Right.
Okay.
And just in addition to Dr. Sergey, other people have used it very successfully in tunnels and in deep cavities in the DFUs, but not only. We actually have now made a new SKU, which is a ribbon. I assume most of you have it, and those are more appropriate for deep cavities.
Okay, wonderful. I think that's it for the questions. As we can see, people loved this. Nearly everyone stayed a full extra half an hour. Thank you so much, Dr. Sergey, Dr. Gadi. It is a pleasure as always.